welcome all of you for the yet another episode of Orthobiologics. And I'm sure this episode will be very enlightening for all of us because this time we will have the most practical use of orthobiological treatment, that is avascular necrosis of hip. So because we have lot of patients who do not want surgeries or whom we can offer non-surgical management. So to address all these issues, we have two experts with us. One is Dr. Anup, who does not require any introduction. He is president of our Indian Orthopaedic Association, and we have Dr. Ramesh Sensor, who is working and whose name is synonymous with avian hip. So without wasting any time, I request Dr. Anup sir to please moderate the session and introduce Dr. Ramesh sir. Over to you, Dr. Anup sir.
Uh, Thank you, Dr. Karun. Good evening, good morning, and good afternoon to all the delegates across the world. First, let me congratulate Dr. Karun for organizing this wonderful webinar because this is one of the very important subject which requires attention, and we all should know how to use actually orthobiologics in avian because as rightly said by Karun, there would be many patients who come early, and at that stage if we intervene probably we'll be able to save many of the hips. So thank you once again, Karun, for having me here. It is going to be a knowledge sharing session. Let me introduce you all, Professor Ramesh Sen. He is a well-known to everybody. He is not just master of avian. I always call him father of pelvic surgery across the globe. I myself have learned a lot of things from him, and he has many published paper in many of the reputed surgeons about the avian. I'm sure today's session is going to enlighten us, all the orthopedic surgeons, about the avian and use of biologics. It is one of the subject which is close to my heart also. And I think everybody should know when, how, and where to use these orthobiologics efficiently in avian. I'll hand over to Dr. Karun and Dr. Ramesh Sen, sir, to start the session.
Thank you, sir. And I'll introduce our team further. Dr. Ashim is there. Dr. Darshan is there from Pune. Dr. Ashim is from Delhi. Dr. Bishnu Patra has joined from Bhubaneswar. And I think Dr. Sathish is also there from Chennai. So without wasting any time, I would request Dr. Ramesh sir to please start his lecture, sir. Over to you, Dr. Ramesh sir.
Thank you, Dr. Karun, for getting me here and giving me this opportunity to talk to friends about avascular necrosis. And thank you, Dr. Anup, to be here with me. Now, when we think about avascular necrosis, all we understand that we are talking about a disease which primarily affects our younger generation. And when these people get this disease, they many times come at a stage when there is nothing possible to do except for doing an arthroplasty. And that is the time you always feel something must be done before that to make it done. Let me have my disclosures first. A part of the research which I have done and I will be presenting is from my work which I have done with as an research with Asian Association of Dynamic Osteosynthesis as well as Association International for Dynamic from the France. They were sponsoring my part of the research work. Now, how my interest started? It was way back in 1997. I was operating upon this case, which came as a 3 months neglected dislocation hip. Now, we all understand when you are operating upon a case which is 3-month-old neglected dislocation, you did reduce it, but you know that avian is very likely. So I started following up this case. At that time, MRI was not very common, but still we could be. He was a driver with one of the companies, and the company doctor was known to me. So I asked him to get his MRIs done and send him regularly for a follow-up from the place where he was working. So I started getting his MRI. Patient was not subsequently symptomatic, and here you can see the MRI showing the changes of avian. And in 98, because I did surgery in 97, 98 things were like that. 2001, the patient was as active, he was doing everything, he was asymptomatic, though we see the MRI changes were really getting bad. And it was in 2005 when he started feeling problem, and you can see the kind of X-ray at that stage. But now he started having pain exactly, you can say, about 7, 8 years after the avian which we had diagnosed on MRI. Now he became symptomatic, and it was in 2007 when he came for arthroplasty, and I did the surgery for replacement at that time. Now this was an issue that when he got the MRI diagnosis and our anticipation so early, he was quite okay for many years. So meaning by whatever we may think about avian, for many years it may remain asymptomatic. And so any evidence of a management given in a short time, say 6 months, 1 year, 2 years, may be relevant, may be irrelevant. It is only when you look for 7 years, 10 years, 15 years, then the things become relevant when we talk about a treatment of this disease. Now we all understand this is a very standard thing, that this can happen from trauma, as I just told you. It can happen from many pathologies which are the vessel related. It could be alcohol, and we all know steroid has a big role, and now COVID also came in. And if you look at these pathological changes, obviously it starts with the cell necrosis leading to hypertrophic cells, the fat cells causing venous thrombosis, edema, stasis, and then gradually coming up ischemia, which eventually causes complete occlusion into the area as the pathology goes on. And I tell patient might present with the pain, or he may remain totally painless for a number of years. But when the pain happens, it happens mostly in the groin area, and it could be anterior, anteromedial to thigh. Physically, if he's symptomatic, it could be an acute pain with which he might have a limited movement and a painful restriction, inability to walk, a limp present. And on the examination, we may find so-called sectoral sign as a positive thing. If you take X-rays at various stages, these X-rays will show various changes. We can make them, and then there will be a stage then when we get a crescent sign, and then there will be a stage of degenerative. We all appreciate it. The same issue says that many a time at early stages, X-rays may be totally normal, as I showed the picture of that case, which for 3 years did not show any evidence on a standard X-rays. So what is expected, a delay of 1 to 5 years may happen between the start of the symptom and even appearance of anything on the X-rays. We all know about the scanning, nuclear scanning. It is there. The problem with nuclear scan is its sensitivity is not very high and specificity is not to the extent of expectations. But we all appreciate it is the MRI which looks like an essential investigation, not only to diagnose early, but to eventually stage the lesion also, whether we get a single band in a T1 image or we look at the second high intensity signal in the T2 image over there. But we must be careful to differentiate this condition from a very near diagnosis of transient osteoporosis, which clinically may not be very different. And an MRI also is likely to show edema, but this edema does extend more into metaphyseal area also. And the difference is that this is a self-restricting disease, which is likely to settle down on its own after a few months. Another is so-called insufficiency fractures, which typically happen in a relatively elderly age group, and we can have the similar kind of a changes, but distinct when you are really careful about reading the MRI pictures. Now, looking at the age, looking at the clinical history and the imaging, we can differentiate that this is not avian, it is an insufficiency fracture kind of a situation. And if we have got a doubt, we can always go to contrast enhanced MRI, which will definitely show us the delay in the perfusion in avian cases. Quite some time back, we started diagnosing or using the fluoride PET CT also and published that. as an evidence, especially in cases where MRI cannot be done for any reason. And we did publish that when we compare it with MRI, it is reasonably very sensitive, 96% sensitive to 100% specificity. And the agreement between the MRI and the fluoride PET CT is very, very much to the degree of 96%. So in cases where there is a doubt about MRI being effective, and many times people don't do due to any metal work in the body also, they don't do MRI. This is the next best investigation that is possible. Incidentally, when we look at the diagnostic criteria for avian, clinical picture does not matter at all. We have X-rays, we have scans, we have MRI, we have histology. And any two positive out of these five, we are sufficient to diagnose the avian as a disease. How often it happens? Now, this is one of the data from different countries. I tried to pull it up. 1.5 to 3 per lakh population, and the same, maybe 1.9 is somewhere from Japan. United States have given a prevalence, South Korea prevalence, and if you look at the China's prevalence also, it is kind of the 1% in men and 0.5% in women. So the epidemiology is like this. In India, we did publish our profile in North India way back in 2015. We did study about 250 patients, 214 with 382 hips. What we found out, that bilateral was there in 53% cases, and we had steroid administration as the maximum cause, subsequently followed by idiopathic and then by alcohol in the series which we had in our population. Now, talking about steroid, the question comes, is it dose related? Yes, there has been a study in Japan which said SLE patient receiving more than 16 milligram per day prednisolone have got 3.4 times higher chance of avian comparing to those getting less than 12. Like with kidney transplant also, they could find it out, a dose specificity for the preponderance of the avian in these cases. Now the question comes, how early after the steroids this avian starts? Now this literature says it can be detected within 16 weeks after transplantation, meaning by giving the steroid also. And the another study said it could that ischemic attack could be there within 2 to 12 weeks after the steroid. So it could be very, very early. The problem is the diagnosis may not be that early, but what is supposed to be there in this publication said it is within 6 months we may be able to diagnose after the administration of steroid whether avian is happening or not, but it may take up till 2 years in that instance. How about trauma? Now, as for steroid, we never know, but trauma is a very specific thing. We know hip had dislocated. We know the fracture neck has happened. So we started this study at that time with the AOD, this thing. We took 30 patients where we were doing open reduction of dislocated hip. We were aspirating the hip right now when we were doing the open reduction. And at that time of the open reduction, because these were all relatively delayed or a neglected dislocation, which did not reduce on the close reduction. So when we were opening up, we started looking at the histology, the aspirate. Very important was to get an aspirate from the superior part of the femur head. And we did aspirate in all of them, and we found it out using a 16 gauge needle, using a 50 cc syringe, making maximum aspiration volume if the volume was more than 1 cc or it was less than 1 cc. So this was what we did at the time of this initial aspiration. And then we followed these cases by 6 weekly MRI till 6 months. Whatever aspirate we come, we did look for its volume. We also looked at the histology, what we got it from the area, this thing. So what we found, we did two things. First, as we followed up their MRI, we found these patients who were all neglected dislocations, and we had done an open reduction. There were many kind of the changes in the MRI picture. But whatever was the picture at 12 weeks, that stayed subsequently. And that made us to publish two things. That the stage 0, that is the early stage of diagnosis of ischemia, which we say is possible at the time when you are operating upon for the open reduction. If it is a deadhead, we can find out that stage also. But what happens most of the time, even we may be doing a close reduction, when the MRI is to be done for AVN, so as a protocol, we advise in all our patients who had got a dislocation, and when you have a chance, meaning by it is more than 12 hours late, a reduction, that let the MRI be done after 3 months. Because because we can do MRI early, but that findings may not be consistent with the eventual outcome. So better to get an MRI at 3 months. If 3 months the MRI is okay, that means post-traumatic AVN is not there. And if it is there, obviously we are getting it out. Incidentally, one of our friends from South India, Dr. Prakash, they have been working on the other characterization, metabolomic characterization. They found it out that these patients have got elevated homocysteine and reduced level of vitamin B6 and B12. They also found it out that they have a higher blood level of sodium and creatinine and reduced of the glucose and hemoglobin in these patients. They further did another study in which they found that you can actually use a biomarker for this osteoporotic can be seen to change along with the management also, and could be a good marker, especially in the post-steroid cases in these patients. So once we have got this thing, we now understand if there is a suspicion of AVN, we do radiography. This may be normal, this may be positive for AVN. If it is already positive, we can go for the treatment. But if it is negative, we look at the suspicion. If it is high, we take MRI. If MRI is contraindicated, right now I can say we can do a infrared PET scan also, and then we can manage it subsequently. Now, what will happen if we don't do anything? This is a paper which looked at this thing, and they found it out that the larger lesions will have no reduction, but smaller lesions which can reduce. Now, the question comes, what is small and what is a large lesion? And there we can take the help of this called modified Kerbal angles. It is basically you take a mid-coronal MRI picture of the head and you take a mid-sagittal picture, have the line drawn from both the levels, both the sides to the center, and whatever angle you find into, you combine it, which is called combined necrotic angle. So if it is less than 190, the two added together, then it is small lesion. If it is 190 to 40, it is a medium size. If it's bigger, it is more than 240 usually. So now we have a definition of what is small, what is medium, what is large. So this concept gave that this size is a very good evaluation method. But further they said it, we must evaluate the volume also, how much is the volume of the head involved, because that may be more reliable than the Kerbal angle. Though it is not, because it is with the MRI people to make that use, but this has been found to another study from our own Indian colleagues is they have found a very interesting thing. They did not manage any case because patients refused, and what they observed was that if the volume size is more than 25%, 90% of the hip will collapse within 1 year, as compared to the hips, which has got a lesion volume less than 25%. So this necrotic lesion volume of more than 25% is a very good cutoff as they described it. So this is a very, very important observation we have to ask for. This paper a few years back showed the same thing, greater size and then lateral weight bearing location. Now it's talking about two things which are likely to be the prognostic factor. And they further said it, what are those prognostic factor? One is edema, where it is. Then is the subcondylar fracture, whether it is effusion, whether it is or synovitis. If these things are there, we have higher chances of eventual shifting over to the THR. But we all have learned AVN from this Fickett classification. where it was preclinical, when it is 0, 0, 0, meaning by once I did a histopathological aspiration, a histological this, that was a stage preclinical. Then we have a pre-radiographic, when we can see on MRI, but we can't see on X-rays. Then we have a pre-collapse, collapse, and arthritic stage. The question is, thereafter, there have been many classifications. Every classification has its pluses and minuses. And this is what this paper has described, again, of an Indian paper, what is good and what is not so good about each classification. So the question comes, which one we should use? Now, what we are looking for, this is the latest one, where they did compare the Fickett, the Steinberg, the Michel, the Arco, and Marcus Anakin. Incidentally, most of us are not using Marcus. We have been using Arco. All the radiologists use Michel. We were using Steinberg or Fickett earlier mostly. But they did not describe one very important classification, which we personally use, that is Japanese Investigation Committee classification. And this 18 paper said this classification gives the best method of assessment because it depends upon the size as well as the location of the lesion, which is very important. And again in 19 also they say this is most promising for two reasons. It is prognostically very good. There is a, and then second, it is very simple to use. What it is? It is this simple, that it is area of involvement. If you look at this line diagram on the first area of involvement, which is very small, but more on the medial side. Then this is the area which goes more toward the superior sulc type B. C1 is the one which is reaching to the lateral side. You can see it is reaching lateral side, and C2 is which has gone across even extent. Now these two type of lesion, you can look at this side. How much this, if it is a type kind of a lesion A, we don't have any collapse eventually happening. If B, might happen 8%. If it is C1, a reasonable number of cases, and by 5 years, C2 or 84% are likely to collapse. So this is a very important classification. We can say type A probably may need no treatment, and type C2, we must be careful about managing these cases. Now, this is 2 years back, this came. What is the prognostic factor for the outcome? It is a systematic review from 88 articles. They defined male gender, longer symptom duration before treatment, higher V scores, and lower HSS scores. Obviously, they are this thing. Now, the question comes, can we prevent this AVN? Yes, we can say about when we have a trauma kind of a situation, if we immediately, at the earliest possible, reduce the hip joint, if we earliest possible stabilize and reduce the femur neck fracture. People feel that if we aspirate the joint after the close reduction also and minimize the injury, we may be able to reduce the chances of AVN, meaning by we may be able to prevent AVN. But can we talk about preventing in post-steroids? There have been studies, or maybe some of the senior people might know. I know at my residency, when we had this diagnosis, we used to give vasodilators because it was considered it is a vascular problem. Give vasodilators and likely to settle down, and complamina retard and all those medicines were what we were prescribing at that stage. Now there has been papers which said it that if the patient has to be on steroids, like dermatological condition when they have to be on steroids for a long time, or any other condition, if we combine with statins, we may be able to avoid the AVN happening due to steroids. So there are chances. The only thing is at that time to have that consultation to be done is a very important part, but there may be. Then there came another paper which said this pulse electromagnetic field stimulation can prevent, it's the experimental study in the rats. They found it can affect the pathogenesis, that it can prevent the AVN also. But if it is happening, the question comes, what is our conventional management? To all of us, whenever patient comes in that kind of a situation, we say restrict your weight bearing. And this is the meta-analysis which says, even if you restrict, It is not a right method. This is not the treatment. And this is because I just show you one of my cases. I did a dislocation, a reduction, and then he had avian. I told him that probably, he says, no, I'll just restrict weight bearing, because at that time he says, I can avoid weight bearing. I'll not allow it to collapse. It collapse. In spite of a bad hip, he is still able to sit and squat, and he doesn't want any surgery. But it does not mean that he is not symptomatic enough that he has been cured of. It is basically he has been asymptomatic with the degenerative hip. Someday he will become degenerative. So we have not actually treated, and actually the rested weight bearing has not been helpful because the pathology has actually increased. This study also showed it out that weight bearing does not contribute to the development of femoral head necrosis. If it has to happen, it will happen. So don't think that if we avoid weight bearing, there will be changes and there will be less changes of necrosis. There have been use of other modalities also. This extracorporeal shockwave therapy, people found, yes, it can do part of the job. And even this HBO therapy, this is a meta-analysis of various studies, and most of them you see are from China, a study from Israel, America, and Taiwan, but rest all studies from China. They have said it could be useful in those early stages. Then the people are talking about ozone therapy. Yes, there has been one or two papers which say, yes, it could be associated with the pain relief, but these are not still so commonly being used. Among the pharma option, people have used various medicine. They found iloprost is one, which they say could be good, but then what they found, if it is grade 2 ARCO, most of them are likely to land up with THR. So it may not be successful. As I said earlier, anticoagulants could be one factor because coagulation disorder is one of the etiological factor. And then in that kind of a suspicion, when that is the possibility, maybe the anticoagulants might be helpful as per this meta-analysis. Then I come to the topic of bisphosphonates. It started with those experimental work done, which said it is likely to be effective in the experimental animals. Then it started shifting over to the clinical study. The two studies came up, one from Taiwan and one from India, saying this could be used good. And this is a case sent to me by Dr. Raja Shekharan when I had a discussion with him about bisphosphonates, because I was not very expecting it to be useful. He says he had, and then he showed that this case after the therapy became symptom-free. And you can see the changes in the MRI and CT. This is the another patient he had where he found that it has become symptom-free, but we can notice that, yes, the patients might feel better with the therapy, but actually whether the things have changed needs a longer follow-up. However, there exists, this was a very beautiful paper which came, how bisphosphonates will help. It is supposed to be that our osteoclasts are more active. They take 3 weeks for the mechanical strength to weaken so that there could be a place for osteoblast, while osteoblasts are a slow one to come up. So if we give bisphosphonates, they will slow down the osteoclast. So the speed of destruction and construction might match up, so they may be useful. Now, this is a meta-analysis done in 2014. If you look at all these studies, you see study 1, study 2, study 3, study 4, all are from Agarwal et al. And when this meta-analysis was, a systematic review was done, they supported it that at early stage, it could be useful for early stage and necrotic because of the evidence. But the other persons who did this meta-analysis excluded Sanjay Agarwal. And when they excluded Sanjay Agarwal, what they concluded was lack of strong evidence for supporting use of alendronate in adult population. Then another review, a randomized control meta-analysis came in 16. They were clear that out of this meta-analysis, it does not support the use of bisphosphonates for this. Another review in 2018, a meta-analysis again of all animal studies and clinical trials. They say despite phosphonates improving in bone remodeling in animal models, no significant efficacy has been observed in the clinical study. So meaning by there is a discrepancy between what experimentally was seen and what is clinically. So they are not in favor of this thing. Now recently there is a paper which is denosumab could be one which could reduce the lesion. But overall, if you look at this picture, it has been seen in this systematic review, which look at all the pharmacological treatments. What they concluded was that no pharmacological prevention or treatment is recommended at this stage. So basically, looking at all those pharmacological barriers, it should not be a part of our treatment therapy in avascular necrosis. As a person, we try to look for other options also. As I was interested in AV, and I looked at whether we have anything in Ayurveda. There are a few case reports only, so you cannot take them as a study. There is no scientific study. Then we looked at homeopathy. Again, there are people who are advising different things, but no scientific evidence till date. In comparison, there are reasonable number of studies in China. And I looked at the kind of systematic and meta-analysis. This meta-analysis is of 23 randomized control studies. They found it could be adjunctive or not, but they concluded that we can't make a firm conclusion that this is useful, so it should not be the part of the treatment in these cases. So this is our latest one of these from India, which said it that bisphosphonates may be tried because this is simple and they don't feed side effects. And there could be a place for biophysical modalities depending upon whatever they found it out. But that was one perspective. Now, at the scenario when we were there, what were the other procedures which were being done at that stage? We had heard a lot about structural bone grafting by putting a pedicle graft, quadratus femoris grafts or muscle pedicle graft. And we all know by the procedure by Dr. Bakshi, his paper on long-term results of decompression and muscle pedicle graft. Then there came a procedure called live bulb procedure, which I did in one of the cases. The patient did improve, but the changes did not improve much. Yes, patient was able to, and this is his 2 years follow-up. He was more comfortable to walk around. I don't have a long-term follow-up. Then there is another procedure which is very much established in the literature is vascularized iliac crest graft. Yes, I did few cases with that also. It is a relatively a major surgery to be done. You take care of the vessel, supplying the iliac crest part and bring that iliac crest part into the hip joint and do it out. Then we did innovate for the another vessel, and we put this vessel, which was a long vessel going inferior branch of the circumflex vessel, and put it down into the hip also. But again, these procedures require careful vascular dissection into the area, which is relatively an extension, this thing. Then there is a procedure which had been called a gold procedure, the gold level procedure, that is a vascularized fibular grafting. There's enough literature that this is effective, but we all know it is a major surgery. 6 to 7 hours taken for taken. And we did these surgeries also, and what we found it out, this is one of my cases coming from follow-up place where we did this vascularized fibula, put it up there, and you can see the hip on that side and here after the surgery, and this is a result of 11 years of follow-up. Yes, he got a wonderful outcome after the vascularized fibula of a bad hip. But let me share, this is definitely a bigger surgery. You need a good microvascular surgeon to be with you, and it has to be defined at a proper time. Now, can we do a free fibula? Are we expecting anything from fibula? Our expectation from free fibula is very limited, that you are basically supporting the bone, preventing the collapse. That is the only thing. And then there has been that you can combine free fibula. Yes, there are still papers that in some stages you can do fibula grafting to provide a stability. And then there came these tantalum rods also, which are not available in India, but they have been there basically to substitute for the lack of fibula or the not taking the fibula, and they found they could support the area of the femur head in that place. And then we did talk about rotating the femur head so that to avoid that area of necrosis. And we all know the name of Suzioka, who described the Suzioka osteotomy. And this slide is exactly from his PPT, which I got from one of my friend in Japan. He sent me these figures of the Suzioka osteotomy. But we know that was too difficult, and now lately this another osteotomy has come, which is called transtrochanteric curved varus osteotomy, which is relatively simpler, relatively more effective at the advanced stages of this disease. But overall, when we have this review, it said in spite of these osteotomies also, THR conversion is 31% of all these osteotomies. So meaning by, in spite of doing all major surgeries, we are still eventually landing up with THR. So people started innovating for the osteochondral graft. They will take it up and do it, or cementation of the femur head, just to buy few years on that point. Now the question comes, they are all the cases, but what to do in relatively early lesions? And again, early lesion, we were talking about core decompression. I said earlier, meta-analysis have shown that core decompression is very effective in stage 1, 84%, 62% in stage 2, and it's much better than the conservative management. And it was also very well defined that the core decompression with the drilling with 3mm pin is sufficient to give us a reasonably good outcome. But if you have got a relatively bigger, we had been using these kind of reamers, which probably 15 years back, I got it from Wright brother from USA and started using them by by getting that expansion of the blade over there, curating it out, then filling this area with the bone grafts also. Then they compared whether this was better than the weight bearing. Yes, it was definitely much better than the non-weight bearing kind of a restricted say. Then people did use a bone graft to fill up the area, and they found it could be one of those things. People started osteoscopy, going through that hole made in the CD to look for that lesion into area and decompressing it. Now, what is the outcome of core decompression? This is not a very old paper, and one of the authors is Vikas Khanduja, we all know. This meta-analysis says that approximately 38 of the percent eventually went for replacement after the core decompression if no augmentation was done. So as a core decompression, again, we wrote it out in 21 only. How should a core decompression will be, when it should be done? So we found the ideal candidate is when the amount of damage is relatively less. Kerbal angle is less, volume size is less than 15%. And technique has to be multiple tiny drilling with using a 3mm Steinman pin, because with smaller holes, we have less complications. People have now moved at places by arthroscopic, and they found, this is again a meta-analysis, that arthroscopic versus open core decompression, this is a safe treatment in for the core decompression. Another paper in this year has expressed the same thing, that arthroscopic core decompression is a better option. Now, if it is core decompression, it can be combined with bisphosphonates also, and they found that it could be a way out of it. Then people started using BMP also, and they found BMP could be, these are the studies that could be able to give us a better result. Then people started using growth factor, gene therapy also, by vascular endothelial growth factors, because they found they are able to stimulate angiogenesis and promote healing, and they could notice the new bone formation in the drill holes also. But let's look back at the pathogenesis. We all understand that in the pathogenesis, what is happening? All the literature says that our mesenchymal stem cells do oscillate between osteoblast and fat cells. And if it is a glucocorticoid, it might induce abnormal proliferation, and we may get more fat cells from these things. While in the bone marrow, we have got pluripotential stem cell, which can proliferate to give everything in the body as such. And we have, as an orthopedic surgeon, enough use of our bone as a cancerous graft at multiple places. So white's marrow should not be good to be used at other places. And now my interest in this started from this very publication, which was there in 2001. It was in one of the journal called Arthritis Research. I was just going through looking at avian. At that time, if you understand, we did not have much of the net available. So I went to the library to look for, and I found this abstract at that stage, where Harnug has presented, and it was an abstract only. He's presented some of the conferences that he put 150 ml of bone marrow as estimated, centrifuged to 25 ml, and he injected into the area of 42 hips at stage 1 and 2, and he was very successful at 5 years. Subsequently, he was a kind of a presidential guest speaker. He presented his work in 2000, 2002, 2004, 2005. And now, as his experience was building up, the same year, JVGS did publish in 2005 another paper of the technique of using it. In between these studies, we had understood that bone marrow cells have got a very good potential. And now we go back to the another issue. Here I had a surgeon friend who got his hip dislocated. He got diagnosed MRI. After 6 weeks, there was something, he got 12 weeks also scan, and he found it is an MRI. He asked, what can be done? I told him, it is 2003, that I have read about a paper. This is what I can do. Should I do? He agreed for it. And next 4 or 5 years, he was okay. And this was his subsequent follow-up, early follow-up, where he showed the MRI picture showed there was an improvement in the pathology of the avian. But another emphasis came from another orthopedic surgeon colleague who got his fracture. You can see the fracture, the transverse fracture acetabulum, which I did the reduction. It was associated with the dislocation, which he has got done at his place. Then he came to me in PJ. I did the reduction, fixation. But he, being an orthopedic surgeon, got MRI done, which showed avian. And then I offered him the same thing. It was in 2004. Do I do it? He said, yes, he can do it. I did it the same way as Harnik has described. Take the marrow, centrifuge it, and put into this area. And now it is 20 years. He has developed degeneration, but his head is still okay. In 20 years have elapsed from that time till date. He's still a close friend of mine right now also. Then in 2005, I thought, why not to study this thing? And now avian was an interesting thing. So we started a formal study. Incidentally, I took it up as my PhD project. So I got the two parts of my study. One part was sponsored by one association, another by another association. I did all those cases. I had all these studies with me. And at that time, there was no this market preparation were not available. So we asked our blood bank people, and they made a small lab for me. They were doing this fical layering, centrifugation, washing, and then all the cultures and all this thing they were doing at that stage. And all those things were doing the centrifugation and the separation, all we were doing at that stage. Then we were using all that count. They were doing the MNC count by using CD34 more than so whatever they were able to find it out. And then I was doing this installation into the area under this thing. It was a straw installation because they used to concentrate to 3 cc, and I had to inject 3 cc, and drop-wise drop we used to take a reasonable amount of the time. Now this was the case again in that very time. You can see it was in 2005. I did a core decompression. You can see the X-rays. You can see the MRI picture. Did a core decompression, but I did not add anything. And within, you can say 14 months, one hip had totally collapsed. The another was also at the collapsing stage, requiring THR. While this case, which came to me with the avian, you can see the kind of a restriction he had. And you can see this was in 2007 when we were working on it. You can see the avian changes right now in the hip joint. And then after 6 months of core decompression, this stem cell installation, these are the pictures. The MRI pictures have settled down. This is 18 months. He was better off. He was clinically also better off. He was radiologically also better off. And 7 years later, his hips were reasonably okay. His all functional abilities were very well over there. Then I present another case in 2007 when these were all my cases during my PhD work. So this is a case where we had defined it. Now I am using GIC for all those cases also. It was a C1 kind of a lesion. I did the same thing. The pictures are there of that time also. You can see it out. And now she's 11 years follow-up. You can see it out. her hip is as best as it can be. Her symptomatology I have already written. She was a case of Hodgkin lymphoma where she had steroids and where then now this is the outcome. She is still maintaining the full functional range, and you can see the Harris hip score is 94, WHO quality of life score is also 96, and she's the one. Another patient I operated way back in 2009. Now this was C2 kind of a lesion as per Japanese classification, and this is him after 11 years. Again, you can notice it out. The hip is remaining, his ability, his sitting and standing is all maintained very well. Another lady at 2007, again, JAC classification was C1 over area. One side was already for THR, another side I did for this kind of a treatment, and she's 12 years follow-up. You can see it out. The side which was not replacement is still surviving with as good a hip as it can be. Another patient in 2007, again, one side was already bad, but another side showed avian at that lesion. So I went for this kind of, and it's a B2 lesion, and it is 10 years follow-up, which you can say the hip has well survived all through this area. This is another patient, 2000 probably 9, which I did, 2007, which she came, one side was bad, went for a THR, another side, I tried to save it up with the same kind of this thing, and this is her 17-year follow-up now in this year. Her hip is as good as possible, as you can see over here. But we did fail in one of the cases. This is one of our failures. So overall, when we looked at all these cases at that early stage in 2012, when I reviewed them, we found it out that the hip survival was much better when we had injected the stem cell, and that is what I presented. It was my thesis also, and we published in Journal of Arthroplasty in 2012 in that area. And now there were all systematic reviews, and because mine was the only study at that time which was apart from Genji study, and the other study which came was Jao study. So in all the systematic reviews, whether 2014, these two systematic reviews included, 16 included, 17 included, 9, and another in 17, another in 19, all these included our study to say the opinion that the stem cells could be useful, or the BMAC could be useful in the management of the avian as such. Now there was an effort how to further refine it out. The people started using PMPs also, combining with stem cells also. Incidentally, in 2009, when I was looking at avian, I published this paper in IGO. And let me assure, it has more than 200 citations for this very paper, because this has been cited by, even lately, by just day before yesterday also, this paper was cited because it was a very comprehensive kind of a statement we had given about what all is possible. But we kept on writing about it, and we have said it out that BMAC is a effective procedure at the early stage. And because we all understand that within the hip, there are bones, there are cells which are getting dead. So replacing with stem cell could be a good substitute in all those cases. But efforts stayed going for seeding, culturing also. And then they tried, can we change the route of administration of these cells? They tried to go through the vessels supplying to that very area, targeting the intra-arterial delivery. By that time, there came a case report that if we culture these cells, the culture cells are likely to give better chances of, because we have got enough number of osteoblasts rather from the marrow stem cell, why don't we give osteoblast also? And luckily at that time in PGI, we started having a stem cell culture lab also. I'm talking about 2009 and 10. So I started using it. We had about 21 cases probably where we did this culture, though I lost the follow-up because I left the institute subsequently. So, but these were the cases. What was special in these cases? You can see these x-rays at that 12 weeks time and see within 6 months how beautifully the changes have occurred into the hip. The patient's outcome was much, much better, very fast as compared to the BMAC. So definitely this is good. Now this is available in the market, and there are these two studies which are published. Incidentally, both are from our colleagues only, and Dr. Vishnu is here. So these studies have said that these autologous cultured osteoblasts are likely to be good in this kind of a natural hip, and they can eliminate the need of hip replacement, and that is what can be said. Again, I go back to the basic definition which Harnig has started, and I had followed from 2003 onwards, that stem cells definitely have osteogenic property. They do secrete angiogenic cytokines. They do have a kind of a presence of cell progenitors for the development of the healing potentials. Now, can these stem cells be combined with something else? The co-decompression can be combined? Yes. This has been seen that in stage 3 also, if we are doing it up, now the BMAC does not help. So if the lesion is advanced, BMAC may not help, and this is again from paper in PGI only, where they have found that in advanced lesion, core decompression can be done, but BMAC does not help in that very stage. But then there was a question in my mind, when there is a stage 1, when there is epidemiology, do we really need BMAC at that stage? So I started doing a study on that. And then what I did was, I defined my patients into group A, where there was a edema and only did core decompression, and another group of patients where we did bone marrow stem cell in them, and find out the difference. And eventually, when we looked at the outcome was not different. Meaning by, if there is no difference in the outcome, that means in stage 1, even if you do not give BMAC, only do core decompression, they have the same outcome. So probably at the edema stage, there is no role of giving BMAC at that stage. It is the stage 2 when the BMAC is likely to be successful in this kind of a situation. Now, talking about, this was all about steroid. What about traumatic? I talked about there could be dislocation, there could be a fracture neck femur. And we all understand in the fracture neck femur, there is a reasonable amount of avian chances in displaced fractures. Undisplaced to displaced, it could be 10%, in men 11%, this is more than men, and all those. Now the question is, what happened in these cases? Now here is a girl who has got a fracture neck, fixation done, fracture united, but it went to avian. Or it is a dislocation which went to avian. So we were, because it's as a part of this, we were doing the stem cell installation along with core decompression, and we were diagnosing them at 3 months because we were getting MRI done in all those cases. We did stem cell installation in them also. And you see, things settled down at 3 years. He has got a good hip. Another case, same kind of a situation, Pipkin fracture dislocation. We did the same study where we have found it out it is avian. You can see the X-ray, MRI picture also. Avian is well defined. Again, we did the same kind of a situation, the stem cell core decompression, and she had a 4th year. She's doing good with the head. Another case with the same kind of a situation and same kind of the outcome we are able to have in these cases. And this is 3 years follow-up. Incidentally, 2015, they say there are no studies devoted to core decompression in the treatment of post-traumatic AVN. And they said in a post-traumatic situation, alone core decompression should not be used, meaning by something should be supplemented. And that is what I showed in last 4 cases, that in post-traumatic situation also, if we add core decompression with a kind of a BMAC, we are able to have a better outcome. And this is the presentation which I made in the one of the ARCO meeting in Chicago. This is that meeting in Chicago where we presented it out that though the traumatic avian overall does not do very well with pure core decompression. And this is what we published subsequently also, that if stem cells are not injected, the core decompression alone does not give a very good outcome in these cases. Now, what are the complications of this therapy? This is one of the standard publication which has laid down, looked at all the literature data of 2,300 patients, and they have found what are the likely complications, and they are just in numbers only. They are not very much to the extent. Yes, there could be pain, there could be post-procedure pain, and some of the cases, this is the main complication as such, otherwise no significant complication. In 2015 guidelines by WHO World Journal of Orthopaedics, they have definitely find it out that we give bisphosphonates to all of them, but we do add the biological enhancement in all of them. Whether you do osteotomy, whether you don't do osteotomy, whatever the stage is, they felt the biological agents must be added to. And you know, how the things change in the current concept review, which is coming from Michael Mount, Michael Mount's work. Here in 2006 paper, he had described multi-potential stem cell as stage indefined, not very well defined. Not A grade, not B grade, but I not defined. But in 20, he pulled it over to B stage, a reasonably good, just nearby the cold decompression, and along with it, he put the cell-based therapy accordingly. Now there are talk about PRP. So the first paper said PRP could be an option, but they said more research is needed to be seen as it is effective. In 23, there came this paper which said it, that if you combine PRP with CD and tricalcium phosphate, it could give us a significantly good relief, and that is what they found. They can improve hip function. In 24, again, they found if you combine PRP with cold decompression bone grafting, it is again safe and effective. But the literature for pure PRP as a properly scientific work is not much. Most of the work lies combining PRP with BMAC. Now, this is a paper which was in 23, which said it is safe and effective to combine PRP and BMAC and plus along with the CD, then compared to a CD. Another paper, however, in 23 said that when you compare this, a meta-analysis, they say it is stem cell therapy combined with cold decompression as the most effective in preventing, not the PRP. Another study, again a network meta-analysis for the invasive treatment, they compared everything. They found, yes, CD, if you combine BOMAC and PRP, could be effective. But he concluded down there that cold decompression with mesenchymal stem cell may be the optimal treatment to effectively delay the prognosis, the progression of avascular necrosis. We come to 2024. Again, the same question. Another studies, higher cumulative survival with the orthobiologics, direct comparison with their control, only BMAC. Now, they are comparing PRP, they are comparing intraarterial, they are comparing mesenchymal cell. The conclusion is that BMAC augmentation in terms of survival from the need of PHA. So there is no benefit of other orthobiologics. It is BMAC only. This is a sum up done in 2024 that some studies have heralded the potential regenerative and cellular therapies, highlighting the emergence of innovative paradigms in the conservative management of AVN. Now, this is again 2024. What he says, orthobiologics have got a lot of potential, and it is again a systematic review. And they say benefits of BMAC augmentation in survivor, in terms of survivor from the need of DHA as such. Another paper, another city, and again you can see they had compared cold decompression, cell therapy, injectable, local, and they found cell therapy is a leading treatment option in this kind of a situation. Now 2025, again they put up PRP along with the BMAC, definitely with the CD, and they say further research is needed to optimize the treatment protocol. Both of them and all of them are likely to enhance when combined together. And again, another paper in 25 again said it, that CD, then again they said, when combined with regenerative therapy, BMAC presents a more substantiated efficacy evidence than any other agent. So again, favoring BMAC only. Now, in between, I talked about, we were using tantalum rod also. They were not available in India, but for some projects I have got in India. And now we have got this, that whenever there is a likely pressure over the femur head, it is likely to break. So we have developed that cannulated solid lattice integrated femur implant, which we can put inside and add stem cell through this, BMAC through it. And there is a specific place for them to come out. And we have got a US patent for this also. And then we have got this emanating from it could be useful to add the BMAC along with the this trabecle rod also. Actually, AVN has become an interest of topic. You can see that various people are working on the various lines in the BMAC. There is a bit of publications now coming from India, but maximum is coming from, you can see, from China, USA, Japan, Germany, England, South Korea, and then comes India. And you can see people are more working now on pathophysiology and the basic research on it. These are my publications which we have done in the AVN series as such. And now this year, while thinking more about it to make the core decompression as an effective thing, we have just published in the Journal of Injury that understanding that BMAC is likely to be useful. But if we have to reduce the chances of the collapse, which is the aim in any femur head after getting this thing, we can look at the mechanical way also. Here what we did was, if we do the drilling with the small hole at multiple sites and weaken the underlying hard bone, that way we are taking away the kind of a stress concentration between the soft bone and the hard bone. Maybe our head is likely to survive better. So if we add a biologics up there and stabilize in a better way and make the lower part of the head, which is otherwise sclerotic, relatively soft, the femur head can work much, much better. So biomechanically we treat, biologically we treat with orthobiologics, and this can work much better. And that is what we have published in this year only in the Journal of Injury. So overall, let me conclude that we all understand that we have got a lot of promising advancement coming in repair of the, and orthobiologics have definitely given us much man option. Rather than the all big surgeries we were doing, now we can reduce the number of surgeries, because we all understand if we fail, replacement is now the standard option. And if replacement is the standard option, how do I counsel the patient? I say this is a therapy which is not likely to affect you much as far as the local morphology is concerned. It is a small procedure and we do not disturb the local anatomy. So we are not using any of the big surgeries, but there is a chance which we can take it up, and by using this orthobiologics or by BMAC, we may be able to save your head, and there are enough chances we may be able to save, and that could be a way for the future in management. Thank you.
Thank you, Professor Ramesh. It was a very elaborative, very comprehensive talk about avian, right from what we had and what is latest. So, Karun, can we have some of the questions?
Yes, sir, surely. And before we have any questions, I can just say one word, wow. Such a in-depth, in-detailed discussion, which is backed by scientific evidence, research papers, and clinical-based discussion. And I am mesmerized to see that entire world is using orthobiological management for AV and hip. And sir, your work in multiple directions is commendable, sir. So hats off to you, sir. So
Thank you.
before I ask my colleagues to ask the question, I have a question to you, sir.
Please.
See, since our PG days till today, we are using the Fickett classification as a standard for all the treatment. But you have introduced, this is the second time I'm listening to you after our East Delhi Orthopedic Association talk about Japanese classification, and you are using it. So, in a simplified way, for my all fellow friends who are like me, who are using only Fickett classification, so is it you are you recommending that we should shift to Japanese classification for all the orthobiological and avian management of the hip, sir? Can you please?
Yes, we must appreciate two things. That if right now, what is my practice? Whenever I see a case, I try if it is a stage two, meaning by we are able to define on MRI the area of involvement. Now you need first to counsel the patient what is his disease. Now, at that stage, my practice is to analyze the amount of area involved using carbon angle. We can, and the location. The location is very, very important. If it is A and B lesions, we can say comfortable, just wait for the symptoms. They are likely to settle down with the time. We don't do anything. And if it is C1 and C2, yes, now this is likely to be bad. And now is the need to be active enough to work for saving your head. If I show saving B1 and A1, there is hardly any use of doing it out. So we have to be rationalistic. If we are prescribing something, we are prescribing for the right thing. And that is the reason if we are doing a research also, if we are doing something, we must be doing on a rationalistic thing where we are defining what is the level, what are the chances otherwise. Every avian will not collapse. And another thing which I said, short-term results are no value. I told you, I started with the example that if we give a 2 years follow-up, 4 years follow-up, it doesn't mean anything. because patient might be just okay for 2 years, 4 years symptomatically. It is only 5 years or 10 years when we might be able to say just this head has survived or not survived. So two things what I feel are essential in the scientific documentation of AVN is appropriate designation of the lesion and the amount and the site of involvement. And second is the follow-up for a sufficient time, not the short time. That they are my learnings in the management of area.
Interesting, sir. Thank you. So 5-year follow-up is actually must to see whether the treatment has been successfully
Yes.
executed or not.
Yes.
So I request my other fellow friends to ask questions to Dr. Anup or Dr. Ramesh sir.
I think before that, I have a question with Professor Ramesh Sen, sir. So you rightly said, so probably this classification is much more valuable to take a decision on the treatment and in a prognostic way as compared to FICET. That is the message, I
Yes,
think.
yes, and it is the more thing. It is a very simple thing. We just have to see the X-rays and MRI and find it out what are the chances, whether we should treat, whether we should not treat. If we have to treat, what are the chances of success of our treatment? And again, there are two things we understand. Now we have got a very young patient who has got a lesion. He may be symptomatic, he may be asymptomatic on one side or the other side. And if there is edema, there is edematous, now he is looking for a result. We should be very clear at that time that we are using these orthobiologics or we are doing these things. So what is the expected result? If I am at a stage, the lesion is C1, I'll be little more expecting. If it is C2, I'll tell him that there are chances not more than 50% I'll be able to help you out. I never say it is 100% because no therapy is likely to be 100%. I have shown the results. It is 60%, 70%. I remember many of the interaction with my colleagues of the various these things it has been asked about. What do you expect when you treat a case with BMAC? I say, if it is a very early stage, it's a very small C1 kind of a lesion, I might expect 60 to 70% of the good outcome. If it is C2 lesion, my expectation is 50%. And then it depends upon the amount of, because what happens, most of this market preparation for the BMAC comes with 40 cc. 40 cc, if you look, is not sufficient to induce the sufficient number of stem cells. It is 120 cc, which we had published. I did not put up that part of it, but that is the minimum essential, and no pack until you use two this thing system, only then you get the sufficient. The second things comes the volume which we get is reasonably big. Now, adding this much of a big volume into the head, which you have just done a small, it's not easy. So I have to spend at least 20 minutes for that installation of those cells into that area. If you rush up, nothing stays there. It is likely to get out. So you have to be very slow. Gravity does help. When you put the patient on the little elevated side on the side, put a bone wax around that area, go for dripping. You take time. We know 16 drops per cc and 5 cc, 80 drops every cc will become difficult and difficult to put in. So spend time. The surgery may take 20 times. Getting this cc into this area might take another 20 times. So spend time if you want the effect to be there. So these things are equally important, and which I am responsible if I am treating this kind of a patient.
So do you do a single core decompression or you use multiple core decompression if you want to put it 120 ml?
One hole is the outer hole into the trochanteric, and inside you do multiple drilling in various directions. And we all understand it is antero-superior. So you are all are directing into the multiple areas, never to breach the cortex. This is the another thing. We should never breach the cortex, otherwise it will get into the joint itself also. So one has to be very careful in getting into the anterosuperior area of involvement, and where you have to get it gradually. Actually, when I was doing my thesis, we were reducing all that into 3 cc only. They were pure Bmax only. Our these days preparations do not make it 3 cc. Their volume is 5 cc or 8 cc or 10 cc. For 3 cc, it was very easy to get 3 cc into that area, into the specific area which is necrotic. The other way we are using it out, when the lesion little bigger, we are curating it, adding these stem cells along with the bone graft. That is the other way we are using them in, if the lesion is relatively big and you have done a coring and the graft and you have curated out the area. That's the other way of using this volume.
Thank you.
Uh,
Sir, I'll touch on it. So amazing talk, sir.
Thank you.
Definitely learned a lot from it. Just like couple of questions in a way, so you can help like emphasize few questions that people always frequently ask. So you did like state that yes, 40 ml bone marrow aspirate is not sufficient. You always have to go higher. So I agree with you that you have to start with at least 120 mLs of bone marrow aspirate. So if we have to quantify it, so are we talking about anywhere upwards of 300 million bone marrow derived mononuclear cells? Is that correct, sir?
Exactly.
So yeah,
Because when we
that's
were working on that, this was something which we have found around. The literature is also very consistent about it. If we look at those studies, what is the number of cells required? It's a reasonably good number. The preparations do not give us that number. So you have to use two these things systems for getting that bone marrow. You can get it out. The processing, you get enough amount of material. Only then it's possible. And then the problem comes: the volume is too much. So
right.
injecting that big volume becomes another difficulty.
So yeah, so the reason I asked her, so I just wanted to emphasize for all the audiences like listening to it. So it also varies from your like technique of aspiration and how you process it. So what we are getting from Dr. Sain's talk is whenever you are trying to inject BMAC, you are looking at like at least 300 million mononuclear cells. So you have to have it to get effective outcomes. Sir, another thing you touched on is like people are trying like hyperbaric oxygen, ozone therapy. So, from your experience, is it worth? I mean, they all like are anti-oxidative, help reduce reactive oxygen species. They're anti-inflammatory. So, is it actually worth combining hyperbaric oxygen or ozone therapy with core decompression along with bone marrow? And if so, what should be the order and when should people be doing it?
Definitely. I mean, any therapy, our aim is to save the hip joint. And whatever is useful, we should be trying to use it, avoiding replacement as much as possible. But we need studies to show that combination is useful. And these studies should be able to show us in a proper scientific way, because prescribing in a clinic should only be done when we have evidence. If I don't have evidence, I cannot keep on trying on experimental basis, because these things may not be available at most places. So if the patient has to go, he must go with that evidence that this is the lesion. If it is a C2 lesion, now I need a therapy. What are the best possibilities for me? I can combine, no issue, but probably we need that scientific work to make it a clinically oriented work.
Yeah, and my last question is before I let other people talk is so we see like whenever we talk about AV and hip, we always talk about BMAC. And we know like yes, BMAC works better than PRP. So from your experience or literature, how about the role of stromal vascular fraction or microfragmented adipose tissue when it comes to the AVN of the hip?
Yes, I have the literature. I don't have my personal experience because I have not used any of them. But literature does support, and some of the papers I did delete from my present paper also, because otherwise I have a huge collection of my slides only. So we did talk about them also in those papers. Everything has a code because it is a evolving science. We are likely to have everything defined to be useful at some stage. But again, there is a two with. One is a research, one is the
Did we lose, sir?
Yeah, I think we lost his connection. Dr. Ramesh sir?
to be useful, no doubt about it, but we need reasonable amount of evidence available.
Okay, sir.
Dr. Bishnu, Dr. Darshan?
Yeah,
Any-
I have a question.
Yes.
Sir, thank you very much, sir, for your such a informative talk. Sir, I am working on this avian for last 8 years, sir. So I have two questions for you, sir, if you can kindly help me. The first question is, one of your presentation, you said that out of 150 ml or 130 ml, you have to inject 25 ml of concentrated bone marrow cells. But without drilling and everything, is it possible to inject 25 into the head, sir? Because I have not tried that method, sir.
Dr. Ramesh sir, are you there, sir?
Yeah. My net was gone. Now it has come back. I'm sorry,
Okay,
I did
sir.
not listen to Dr. Peters because the time when he started, my net was off.
So I will once say
So
it is. So
please.
thank you very much, sir, for your nice talk, and it was very informative, sir. So just what I wanted to say is I'm working on avian for last 8 years, sir. But I've not tried
Mhm.
injecting 25 ml of bone marrow concentrate into the head without drilling. So how it is possible? Because can you, sir, say me that and that, sir?
No, if you read, that is very interesting thing. When I read for the first time Harnik, when he presented it, I'm talking about 2003. When I read
Sir.
his first article, and I tried doing it to my patient, injecting 25, everything was flowing out. You
Yes,
can't
sir.
have 25 cc inside it. But then I got the other paper which I quoted from JBJS by Ganges technique. There he has defined it out. And then when I took it as a project, because it was my PhD project. So when I took it up as a project, we had clear definitions that it's not 25 ml, it is 3 cc or 4 cc only, but the number of cells are more important.
Okay.
So then we had the lab preparing us with that. I mean, for the research, I never used 25 cc. It was Harnig who said it is 25 cc. No other author has ever said 25 cc.
So one more question, sir. Sir, nowadays there are literature saying that they're
Please.
injecting BMAC into the joint even along with the head. So my question is, in couple of times, I have pierced the cartilage and gone into the joint, sir, because the suddenly I give up and the bone is so poor that I go into the joint. So in such cases, what will be the outcome, sir? Because many times, because in the both cases, you are injecting BMAC into the joint, also to the head. So here, if automatically the fluid goes to the joint, is there any major problem, sir?
Now there are two things. First, we expect a certain amount of a cell to stay within that area.
Okay, sir.
Now that cell is not staying into that area. So there is a depletion of these cells over there, so it may not be effective. The joint
Okay,
volume
sir.
is so much, it may never be possible to have that level to that an extent that it is likely to help the lesion on that side also.
Okay, sir.
So I feel we may be losing the effect in that way.
Okay. Thank you very much, sir.
Sir, I just want to highlight Dr. Ramesh sir and Dr. Anup sir. An interesting point about Dr. Bishnu Patra. He is heading the department of at AIMS Bhubaneswar, and I think this is the only center in India which is having almost 7 to 8 theses which are going on orthobiological management in orthopedics in various fields.
Yes,
So
sir.
hats off to you. It's the
Thank
emerging
you, sir.
science and the pinnacle institute of a state is working so much. So Anup sir and Dr. Ramesh sir, I want to congratulate Dr. Bishnu Patra for
Thank you, sir. Thank you
doing
very much.
such a pioneer work in orthobiologics.
Thank you,
So
sir.
I request Dr. Darshan to please come up with this question.
Congratulations.
Yes, sir. Congratulations. Excellent talk by Dr. Ramesh and sir. I mean, sir, you gave us an insight into each and every small, minute details of the various therapies or treatment modalities that are available for management of AVN. So I'd like to ask a simple question. I mean, even you mentioned, most of the patients have bilateral involvement. So when we talk about core decompression with or without any other adjuvant, so whether it is just core decompression or whether you're adding a BMAC or an autologous osteoblast cells injection, then in these cases, do you recommend doing both at the same time or one and then after some time the other?
No, I mean, I look at it, what is the activity status? Because
Okay.
there must be mostly what happens. One side is active, another is not active. And now I define the amount of area of involvement. If that area is A and B, I'm not likely to touch that side. If there is no edema, I'm not likely to touch that side. If it is edema on one side and a lesion is stage 2 on one side, yesly, I'll do a core decompression. And on the side where the lesion is defined, I'll do a core decompression and I'll add BMAC. So I will do at the same stage if the both need. Then I will not stage it.
So if both are severely involved or both are
Yes,
stage
yes,
C,
yes, yes.
both
I'll do
sides
it.
simultaneously.
Yes.
And then in that case, and do you, I mean, immobilize or keep the patient in bed for a few
No,
weeks?
no, 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 no. We do with the small needle. There is just a 4 millimeter hole. And again, if I don't know how much time we have got it.
Sir, we have another 10 minutes, sir.
Okay,
If
so
you
let me share with. I had never, I must have done so many. I've never had any pathological fracture coming except for one patient. And that was way back in, I think, 2013, when I got a patient from Ujjain. He came because he was brought by my professor, orthopedic colleague from Ujjain, with the perspective that this is to be done. I did it. Second day post-op, he got fracture subtrochanteric on one side. Third day, fourth day, he got fracture on the other side also. And it was a small this. And it was surprising thing, though patient's attendant was not, they were okay. They said, okay, sir, we have found it out. He was kind of a pundit that he will have a bad outcome wherever he gets the surgery done. So they were expecting a complication. And actually, we were worried about why this should happen when it never happens. So we studied his samples sent to USA by endocrinology colleagues, and it was what you called silent, what you called, where the pathological fracture happens. I'm just forgetting the name. Disease. Yeah. So this was this kind of a problem which has led to this thing. And we got the diagnosis from USA, and then told him, I met him after about 10 years, it was okay. But that is the only case we had a fracture. Otherwise, this small 2cc hole does not make anything. We advise them relative restricted activity. It's not lying bed rest. Relative restricted activity that you can be within the house. That's all.
Okay, sir. Okay, sir.
Thank you, sir.
That's
So,
thank you, sir.
thank you, Professor Sensor. We deeply appreciate the clarity, the balance, and depth you brought to this important topic and the evolving area of orthopedics, that is orthobiologics. So, before we conclude, I request Dr. Anup sir to please give his concluding remark as a moderator and as our president of IOA to our past president, Dr. Ramesh Sensor, sir.
Thank you.
I think this is the one of the best talk and most comprehensive talk I ever heard about avian on the hip, and truly a master class by Professor Ramesh Sen. And I think most of the delegates would have got a clear cut mandate that BMAC and CD is the treatment of choice for most of the avian patients. It is necessary to act early when you diagnose whether it is edema or C1 or C2 lesion. And if you act properly, then probably the hip is going to be saved. It is definitely an emerging science. It is daily evolving. We'll have to keep a watch on what is evolving. As rightly said by Professor Ramesh Singh, there are two aspects. One is research and one is established. So we have to look what has been established clinically, which is beneficial to the patient. We as a clinician cannot go for a research on the patient. So as a clinician, we have to do a procedure which is evidence based, well established, while the researchers will keep on doing. So wait for researchers to get established, clinically proven, then attempt those. Otherwise, do a well evidence, clinically proven procedures to the patient to help the society and the patient. Excellent talk, sir. Thank you very much for giving us insight on the avian. I'm sure we all have learned a lot about the avian.
Um, Again, thank you, Dr. Anup sir, for joining us in spite of being busy in a family commitment. And I have no words to thank Dr. Ramesh Sen sir for giving such a insightful and in-depth discussion, sir. So I would conclude this session, and I request all the viewers stay tuned till the time we come up with the next episode of Orthobiologics. See ya. Have a good night. Thank you, everyone.
Thank
Thank
you.
you,
Thank
Karun.
you.
Thank you,
Thank
sir.
you,
Thank you.
everybody.
Thank
Thank
you,
you,
sir.
sir.
Thank you,
Thank
sir.
you. Thank you.
Thank
Bye
you, sir.
bye. Take care.
Thank you, sir. Thank you, sir.
Thank you, sir. Thanks.